I'm going to be talking about a topic which is literally hot from the stove, and that is type 5 diabetes. This condition was reported first in 1955 from Jamaica and was initially called J type diabetes. It was classified by the WHO in 1985, but was removed in 1999, citing a lack of convincing evidence of a causal association with malnutrition. It's now estimated that there are about at least 25 to 30 million patients, maybe even more. So this is a publication taken from Lancet, which shows the cutoff points for BMIs as far as leanness is concerned. And South Asia, as far as we are concerned, means leanness with a BMI less than 19.2 kilogram per meter squared. Now, actually, what we found in the study is that they were very insulin sensitive. There was no evidence of insulin resistance, which confirms the fact which other studies had also shown. You can see the BMIs of all our patient groups and the type 1s, which are compared, type 2s, typically obese, and the lean normals and the overweight normals. Now, what we found is that the beta cell function was deficient, the blue line over here, in type 5 diabetes, but was not as low as type 1 diabetes. So they have insulin deficiency, but is not as profound as type 1 diabetes. This is a very typical characteristic form of diabetes, which is different from type 1 or type 2 diabetes. It's a privilege being here today and being enabled to give this particular talk. I'm sharing my slides now. Do let me know if you can see them. Right. So I'm going to be talking about a topic which is literally hot from the stove, and that is type 5 diabetes. I'm going to be trying to look at how we have arrived at this particular disorder, what it means, and why this particular name has been given at this point of time. Uh, what I'll be doing is I'll give a little introduction and background. Then I'll talk about the pathophysiology and the pathogenesis of this disorder, why it happens, uh, and one aspect in terms of its the prenatal and postnatal undernutrition through the research which has been done, what conditions you need to think about and rule out, and the approach to the differential diagnosis, and also a little bit about one particular disorder, a subgroup of type 2 diabetes, the severe insulin deficient form of diabetes. Is there an overlap with this particular condition? So, this particular disorder is not a new disorder. It was first reported in the year 1955 in Jamaica and was called J type diabetes. In fact, reported by Jones and published in the Lancet in 1955.
Hello,
In
sir.
the year,
Sorry to interrupt. We don't see your presentation. Can you screen share?
so I'm going to talk about a disorder which is in fact a fairly important condition which has been reported over the years. Having said that, it's gone through many ups and downs as far as its classification is concerned. So I'll be talking about the introduction and the background, type 5 diabetes, why does it happen, a little bit about why low birth weight and undernutrition make a difference to this condition, the differential diagnosis and the approach, and something which is related but not particularly the same, SIDD. Does it overlap with type 5 diabetes? So, going to the history, and I hope this is visible to you. This condition was reported first in 1955 from Jamaica and was initially called J type diabetes. It was classified by the WHO in 1985, uh, but was removed in 1999, citing a lack of convincing evidence of a causal association with malnutrition. And also, in addition to that, people thought it was misclassified, a form of type 2 or type 1 diabetes, which was probably undertreated and they were just losing weight. Subsequently, it was reported in many other countries, including India, Sri Lanka, Bangladesh, many African countries in particular. And it's now estimated that there are about at least 25 to 30 million patients, maybe even more. Now, due to the lack of formal recognition, this has been largely understudied. And until a study which was published in 2022 in Diabetes Care, a joint collaboration between the Albert Einstein in New York and CMC Vellore, uh, this condition was in fact characterized. The physiology was then reported thereafter. If you look at this particular slide, I'm going to actually define what we mean by lean. And the South Asian population, essentially, we talk about leanness with a BMI less than 19.2. So the word lean is misused. Different parts of Africa have to decide upon their regional normatives, very different from what we talk about lean here. For example, in East Africa, one might have leanness as BMI of 21, and in West Africa, it may be about 25 kg per meter squared. So, different parts of the world, the cutoff is lean. Now, I'm showing you a photograph over here, and that is incidentally me at the age of 19 years. BMI of 18.5, but not malnourished, quite a bit of muscle mass at that particular point of time. And from this particular talk, young or youth means less than 30 years of age. So this is a publication taken from Lancet, which shows the cutoff points for BMIs as far as leanness is concerned. And South Asia, as far as we are concerned, means leanness with a BMI less than 19.2 kilogram per meter squared. So there's an exponential increase in the number of patients with young diabetes over a period of the last few years in India. And between the age groups of 18 to 35, it's almost a 73% increase in the prevalence of young diabetes. And you can see the states over here, which include the largest increases in prevalence of diabetes. Coming back to the basic topic which I'm talking about, this particular disorder, malnutrition-modulated diabetes, or more specifically called protein deficient diabetes, was classified by Samal and Tripathi way back in 1996, talking about overt hyperglycemia with more than 200 milligrams, largely rural individuals with a low BMI, grossly malnourished, but an absence of ketoacidosis and presence of a high insulin requirement. So these are the conditions which are the associations with this particular condition. In addition to this, this particular condition is associated with was associated with a high insulin requirement. So when you have a lean person with a BMI less than 19.2, these are differential diagnoses that one should consider. So type 1 is certainly one particular disorder. But besides that, we have other conditions which include fibrocalculous pancreatic diabetes, monogenic beta cell dysfunction, Wolfram syndrome, and lipodystrophy. And if you look over here, the ones which I have labeled in green are relatively more common. The ones in blue are less common. And then, of course, we come to type 5 diabetes, which I'll be covering in detail. So, what is the prevalence of lean diabetes or BMI less than 19 in the Indian population? It can vary from state to state. And this is a study which was done in our part of Vellore, looking at the urban prevalence of diabetes, of lean diabetes, 2% in rural areas and 1% in urban areas. And this is Tamil Nadu, which is a relatively higher GDP state compared to maybe other states wherein the prevalence of this condition may be more, maybe as high as 8 to 9% in certain states of India. So, why does type 5 diabetes happen? So, I'll talk about looking at this particular slide, and you can see over here that you have a number of factors which are associated with the evolution of type 2 diabetes. A number of conditions, almost 21 different disorders which are associated or predisposing factors which are associated with the evolution of type 2 diabetes. But I'd like to focus over here on one particular determinant, and that is low birth weight. And low birth weight, interestingly, is associated with the evolution of type 2 diabetes as well as type 5 diabetes. These two publications in Lancet actually talk about the issues of inequity and diabetes outcomes and the evolution. And it's important to note that low birth weight, and this is actually the Barker hypothesis over here, wherein Hales and Barker, way back in the year 1991, from the Herefordshire cohort, described that if you're born low birth weight, your risk of developing type 2 diabetes is greater, obesity is greater, hypertension is greater after a period of 30 years if you're born low birth weight. On the other hand, if you're born high birth weight and your mother did not have diabetes, there is no added risk for developing type 2 diabetes. Now, this is called the thrifty phenotype, wherein if you're born low birth weight, you accrue more fat, more insulin resistance, and your cardiovascular risk, hypertension, and diabetes is greater. This was subsequently reported in many retrospective cohorts, and this is the Dutch hunger winter, which I'm showing you over here. In the Second World War, wherein people who were exposed to very low calorie intakes, many of them were women who were pregnant, they had an increased risk of developing diabetes about 30 years later. Let me point out that if you look at the distribution of birth weight, the highest prevalence of low birth weight and the lowest uh, enabled low birth weight is actually seen in the Indian subcontinent. This could be partly an inherited capacity, a translational issue, but it is also a fact that there may be a component of undernutrition which is higher in these countries. Another entity which we call severe acute malnutrition is also more common in certain tropical areas, particularly across. And you can see the map over here that shows that the prevalence of severe acute malnutrition is in fact greater in the Indian subcontinent as well. So, bearing all this in mind, why does type 5 diabetes happen? And I'm going to focus once again on the low birth weight issue, the Barker hypothesis. These are experiments which we did in Vellore about 15 years ago, looking at young individuals, 50% who were normal birth weight and 50% who were low birth weight. And we looked with very intricate experiments at insulin sensitivity. I told you that the percentage body fat in the body is greater if you're born low birth weight. And this is at the age of around 19 or 20, BMIs of around 19. When we compared those who were normal birth weight versus those who were low birth weight, the low birth weight were shorter, they were lighter, they had a reduced muscle mass, had mildly increased diastolic blood pressure, but at that point of time, at the age of 19, with a BMI of 19, they did not have an increase in insulin resistance. They had the same insulin sensitivity between the normal birth weight and low birth weight. The low birth weight individuals tended to eat a low protein diet, and this is a habitual practice which they had from an early point of time in life. When we put them on a bicycle and made them exercise, we found that they had an increase in their muscle mass. There was a difference in fat-free mass and body weight. In fact, the muscle mass improved. So the low birth weight individuals actually responded to physical activity and exercise. And this is a point which I'm going to emphasize when I talk about the treatment of type 5 diabetes. The percentage of body fat, as you can see over here, was lower. They also had much lower liver fat, these low birth weight individuals, when they were lean. Yajnik from Pune has actually shown that individuals born low birth weight have an increased risk for impaired glucose tolerance, and they had a declining beta cell function by the time they were around 20 to 25 years of age. Look at this particular slide, and I was intending to show you the differences between marasmus and kwashiorkor. We no longer see kwashiorkor very much in India, but we still do see individuals who are undernourished and who have marasmus. And people who have marasmus, according to the study from Jamaica, which was done about 10 years ago, have a tendency to have a greater history of low birth weight. They also have a lower insulin secretion, they have insulin deficiency, and the glucose levels are also higher in those who have marasmus. So this is setting the stage for people who have undernutrition and people who have low birth weight, two factors which merge together and increase the risk of developing this form of diabetes, previously called malnutrition-modulated diabetes, but now called type 5 diabetes. There have been animal studies in the past, almost 30 years ago, which have shown that insulin is deficient and they have a lack of response to amino acids. Animal studies have also shown that with malnutrition, the islets are actually smaller. They have micro islets when compared to normal individuals who have a greater proportion of macro islets over here. So all this indicates that people who are born low birth weight and subsequently have undernutrition, that the tendency for beta cell dysfunction is greater in these individuals. So when we talk about low BMI diabetes, and this map shows the prevalence of what we call today type 5 diabetes, and also another condition called fibrocalcic pancreatic diabetes, the important differential diagnosis, occur in a particular belt, which is largely tropical parts of the world. So as I mentioned, this condition was initially called J-type diabetes and was described by Jones. Subsequently, cases were reported, and this is, in fact, way back in 1962 in East Pakistan, that's before Bangladesh became independent, that there was a high proportion of these patients with malnutrition-modulated diabetes. More recently, in the last 6 or 7 years, we have studies from Jamaica, Uganda, and Ethiopia showing that this phenotype is in fact quite common. And this study, which was done in Uganda, actually shows that a significant proportion, almost 11% of individuals from Uganda with diabetes have this form of diabetes, and they are indeed having low percentage body fat. Normal body fat in a person like perhaps me would be around 23 to 24%. If you have type 2 diabetes, it would go up to around 30%. But these individuals have a percentage body fat of only around 13% over here, and they also have defective beta cell function as evidenced by low C-peptide measurements in these individuals. So I've talked about the issue of low birth weight, subsequent undernutrition, and beta cell dysfunction. And I'll also talk about certain experiments which were done back in India in All India Institute of Medical Science in 1999, published in JAPI, showing that these people with undernutrition have no evidence of insulin resistance and they have a high insulin requirement. More recently, from Thailand in 2009, this study has actually shown once again that there is no peripheral resistance. Unlike type 2 diabetes, these lean people have no evidence of insulin resistance. This is our study, which was done and published in 2022, a joint collaborative venture between CMC Vellore and the Albert Einstein Medical College in New York. It's a very elaborate study which took almost 7 years to do and involved patients with type 1 diabetes, type 2, lean controls who had low BMIs of less than 18.5, overweight controls, and people who had this particular condition, malnutrition-modulated diabetes, with BMIs less than 19 kg per meter squared. So what did we do? We did these elaborate studies, the pancreatic clamp studies, which are very elaborate studies which take almost, something like 10 to 12, 24 hours to actually do over a period of time. They all have a certain degree of control of glucose, and the glucose values are clamped at 90 milligram per deciliter for a period of almost 6 hours. And we infuse insulin and glucose at the same time. The more insulin you infuse, it indicates that they are more insulin resistant. Now, actually, what we found in the study is that they were very insulin sensitive. There was no evidence of insulin resistance, which confirms the fact which other studies had also shown. You can see the BMIs of all our patient groups and the type 1s, which are compared, type 2s, typically obese, and the lean normals and the overweight normals. Now, what we found is that the beta cell function was deficient, the blue line over here, in type 5 diabetes, but was not as low as type 1 diabetes. So they have insulin deficiency, but is not as profound as type 1 diabetes. They also had, uh, in addition to that, an increase in, they had a hepatic glucose production over here, the blue dots as you can see, which was lower than type 2 diabetes. If you remember that patients with type 2 diabetes have increased gluconeogenesis, increased hepatic glucose output early in the morning. Now, our patients over here did not have as high a glucose output when compared to type 2 diabetes as marked over here. They also had a number of micronutrient deficiencies as well as protein deficiency. So, in summary, what our experiment showed is that these patients did not have an autoimmune or genetic etiology. We did genetic testing for 62 genes to rule out genetic causes for young onset diabetes. They had BMI levels far lower than compared to what was seen in Indian studies. They had poor insulin secretion, not as bad as type 1 diabetes, but they did have a low insulin secretion. The hepatic glucose output was lower than type 2 diabetes. The fat in the liver was very low, and the percentage body fat was extremely low, much less than 20% in these individuals. So this is a very typical characteristic form of diabetes, which is different from type 1 or type 2 diabetes. So I'll go next to the differential diagnosis, and I showed you a list of conditions wherein this particular disorder can actually occur. You can see over here that the first thing which I'm going to be thinking about is type 1 diabetes or slowly evolving immune-mediated diabetes. So over here, the salient features in this form of diabetes is when you have type 1 or slowly evolving immune-mediated diabetes, they have an antibody positive. The older ones have only a single antibody positive or GAD antibodies, which are positive. There are no signs of insulin resistance. Their C-peptides are low, and they, of course, need insulin early. Invariably, within 2 to 3 years, 100% of them will require insulin treatment. Next, I go on to fibrocalcific calculates pancreatic diabetes, wherein I give you a classical case over here. A young man with abdominal pain and a marked weight loss, history of diabetes for more than 3 years, and a BMI of 20.5 kg per meter squared. He has gross malabsorption or a stool fat of less than, stool elastase of less than 20. And you can see the calcification with ductal calcification, which is seen, which is very profound over here, and a shrunken pancreas. This particular disorder is found largely in tropical areas uh, and is perhaps the most important differential diagnosis to rule out in someone who has a low BMI other than type 1 diabetes. So you have a BMI less than 19, you should think of fibrocalcinosis pancreatic diabetes. It's not rare. It's very important once you have a low C-peptide level. Please do an imaging of the pancreas with an ultrasound. An ultrasound is operator dependent. Therefore, it is better to do a CT scan, which will pick up nearly 95% of patients with fibrocalcinosis pancreatic diabetes. These individuals also have, you can see the prevalence over here in a Lucknow study, wherein we were involved with the genetic analysis. 15% of them, of these people less than 30 years, had fibrocalcinosis pancreatic diabetes. FCPD has many characteristics. They have an increased prevalence of autonomic dysfunction, more micronutrient deficiencies, and they also have this peculiar phenomena of increased glucagon secretion in the early phase. And this glucagon is probably originating from the intestine rather than the pancreas and stimulates the mitochondria to increase the energy expenditure. So we have also established that they have an increase in energy expenditure, and therefore these individuals need insulin, they need enzyme supplementation, and they also need a very high carbohydrate diet. So it's a distinct, very important differential diagnosis for type 5 diabetes that we need to have over here. So I'm just summarizing the features of this particular condition which we should be aware of in our population. The second important differential diagnosis is the monogenic beta cell dysfunction, the inherited disorders which are classically autosomal dominant. These conditions include a number of conditions. The classical MODIs, there are 14 types. In the Western population, we have the glucokinase deficiency, which is the most common. But in India, that is not as common a disorder. Here's a classical patient with the pedigree chart, the strong paternal history, 23-year-old male, three-generation family history, responding well to sulfonylureas, and this is a MODY1 mutation, as you can see over here, HNF4 alpha, responding to sulfonylureas. Here's another young girl, 16-year-old, on thrice daily insulin, a history of recurrent renal stones from the age of 12 years, and from 14 years had cyclical low abdominal pain, no steatorrhea, and because of her amenorrhea, she had her pituitary hormones checked, which were normal. Imaging showed evidence of a uterus, which was basically, you can see over here, a biconate uterus, and she has an atrophic pancreas. So this particular disorder has a syndromic presentation with young onset diabetes, and we thought in terms of a MODY5, HNF1 beta mutation, which established this. So this is another important, these monogenic disorders, particularly MODY5, can be extremely lean. Here's another gentleman who's 20 years old, recurrent respiratory infections, history of steatorrhea, very low BMI, and had low C-peptides and a GAD antibody negative, and malabsorption. This is a fat replaced pancreas, you can see over here. And the genetic testing shows evidence of cystic fibrosis along with a SPINK1 mutation, which is also seen in fibrocalcic pancreatic diabetes. But essentially, this confirms a diagnosis of cystic fibrosis. And this is an increasingly common disorder which we should be aware of in adolescence and childhood, which can cause diabetes, which may be lean and may have history of respiratory infections. A 43-year-old lady who had had diabetes for 15 years. The initial phase came with like an acute pancreatitis, and you can see an edematous pancreas over here. CT scan during her episodes. Subsequently, you can see that eventually she had an atrophic pancreas with calcification, uh, and she was being treated like a fibrocalcic pancreatic diabetes. But her daughter came with recurrent episodes of headache and extreme fatigue, recurrent migraines, and a very high lactic acidosis. And this is blooming of the globus pallidus, you can see over here. This is a mitochondrial encephalopathy with the lactic acid excess in this patient. Uh, so biopsy showed evidence of ragged red fibers in the muscles, and the genetic testing over here shows evidence of mitochondrial uh, mutations, which caused young onset diabetes in the mother, but caused a mitochondrial myopathy in the daughter with a MELAS syndrome. So when you have a lean person with an inherited condition, low C peptides, we need to, and the pancreas is shrunken but no evidence of calcification, we now have a pancreatic diabetes associated genetic panel. Coming to less commoner conditions wherein you can have lean diabetes as a differential for type 5 diabetes, lipodystrophy. This is a 38-year-old lady diagnosed with diabetes at 19 years of age, presented with hyposmolar symptoms, diagnosed as type 1 diabetes. Subsequently, you can see over here that the percentage body fat done on a DEXA scan is extremely low. It's only around 12% to around 14%, 18% or so in its overall distribution, much lower than what you'd expect. This patient required almost 400 units of insulin per day and had these prominent veins, phlebomegaly, and had a very high triglyceride level. The C-peptide levels were also elevated, indicating that this patient had severe insulin resistance. So it's not an insulin deficiency, not a low C-peptide, but insulin resistance in a lean person. And this is a partial lipodystrophy. These patients can respond well to pioglitazone, which therefore when you start it, you can cut down the insulin requirements. Here is another extreme case, more severe, a complete lipodystrophy with stunting of growth, very high insulin requirements, more than 600 units per day, high triglyceride levels, grade 4 fatty liver progressing to cirrhosis, and very low percentage of body fat, only 10% body fat. And that's a complete lipodystrophy on the genetic testing. So this is a series which was published by our department on lipodystrophy and the genetic screening that we do in these patients. They have high C-peptide levels, severe hypertriglyceridemia, and the distribution of body fat is very, very low. So this is not like type 5 because they have very high C-peptide levels, which prove the diagnosis. And of course, the insulin requirements are extremely high, which once again does not fit type 5 diabetes. They have fatty liver, which is not seen in type 5 diabetes. And the mutations, the genetic testing, of course, shows mutations in these patients. Finally, a condition called Wolfram syndrome, which we should think about, autosomal recessive. But the Wolfram's like it tends to behave like an autosomal dominant condition. 20-year-old lady who looked a lot like type 1 diabetes for many years. But in addition to that, when he had high glucose levels, never developed ketoacidosis, C-peptide levels were low, but also had a dilute urine with a high sodium, indicating that he had diabetes mellitus and diabetes insipidus at the same time. Sister had uh, diabetes from the age of 8 years, progressive loss of vision, deafness, seizures, and subsequently succumbed to her illness at the age of 26. This is her testing, which showed evidence of severe sensorineural deafness and also had evidence of optic atrophy, as you can see over here, and the ganglion layer, which is evident on the OCT, which is grossly atrophic. So you can see the imaging of the brain showing an atrophic brainstem and pons, and the genetic testing confirming a diagnosis of Wolfram's like syndrome. Now, this condition generally requires insulin. Rarely, if they are heterozygotes, they may be responding to glimepiride. Uh, but the important thing is you should think about this condition in someone who has negative antibodies for type 1 diabetes, normal enzymes of the pancreas, because in the initial phase, and you look at this chart, this is the age as they progress, diabetes comes on first, then the optic atrophy. And so you wouldn't think in terms of Wolfram's in the initial phase unless you do the genetic testing. Then the hearing defect and the other manifestations later on in life. So genetic testing is mandatory for these young individuals who have these presentations with insulin requirement, low C-peptide, no ketoacidosis, normal CT abdomen. We have to do genetic testing to prove the diagnosis. Finally, coming to the condition which, of course, we are talking about today, and this is type 5 diabetes itself. Uh, we had a consensus meeting in Vellore about 5 months back, and this is the publication which is going to be coming out in the next month and a half, which will label this condition as type 5 diabetes, which was declared in the IDF meeting in April 2025. Uh, and here is a prototype case, a 17-year-old man coming with a lean phenotype from a rural area on treatment with oral antidiabetic agents in the initial phase. Weighted time of diagnosis 49 kgs, fasting hyperglycemia, and weight loss over a period of 3 years. Uh, the important thing over here was the birth weight, which was there in the history. Fortunately, in this patient, 2 kilograms, and we have this habit of actually asking our patients, what is your birth weight? If they don't know, we ask them to call their mothers and ask them, what is your birth weight? Belong to a low middle class family, and you can see over here the low BMI, no other systemic findings, reasonably normal looking lipid profile, suboptimal glycemic control, no evidence of fatty liver and a normal pancreas. And of course, we did a CT scan which also showed no pancreatic atrophy. Low C-peptide levels, but with some surge in C-peptide after a mixed meal challenge. It did rise, indicating some beta cell function, but suboptimal in the fasting state. No malabsorption, and no evidence of type 1 diabetes. The percentage body fat is low, 17.4 on a DEXA, which is, of course, extremely low, less than 20. So this patient also had genetic testing, and this is, of course, from an academic perspective. We did a 62 gene panel, but you don't need to do it. There was no family history, but this is from a research perspective. So therefore, this patient is lean, young onset, non-autoimmune, fasting insulinopenia, normal pancreatic structure, low total body fat, non-ketotic without a classical genetic disorder. This patient qualifies for type 5 diabetes and he was managed with glimepiride 3 milligrams once a day. So when we look at our treatment profile, as in the diabetes care article, we find that 50% of these patients can be managed with oral antidiabetic agents. And that is the good news. You do not need insulin in 50% of these patients. How do we treat them? Insulin therapy in 50%, oral antidiabetic agents. It's yet to be determined as to what would be required. We know that metformin has many effects besides working on hepatic gluconeogenesis. It has other peripheral effects in addition. And a subgroup of these patients seem to respond to metformin in addition to sulfonylureas. To stimulate the beta cells, we have to try and give a high protein diet, and we need to build up the muscle mass to improve glucose absorption. Therefore, resistant exercise and aerobics are actually quite important in these patients. We're still in the process of developing the diagnostic criteria, but here, tentatively speaking, they are generally young, less than 30 years of age. They're usually not found in children. Poor low socioeconomic status, lack of a strong family history, low BMI, no ketoacidosis, low C-peptides and absence of antibodies, low birth weight. If you can get that history, is very useful. Absence of acanthosis nigricans or signs of insulin resistance, absence of radiological features of pancreatic disease, and low percentage body fat. Now, we have this algorithm which we can do, but if you're in a low resource setting, take a good history, look at things like birth weight, socioeconomic status, draw a good pedigree chart to rule out inherited causes, check the fasting C-peptide levels, measure GANT antibodies, imaging of the pancreas to be done, and if you can check percentage body fat, it's good. Finally, SIDDO, the severe insulin deficient phenotype of type 2 diabetes. We now have this cluster classification of type 2 diabetes, which is not in the WHO classification, but people now divide type 2 into forms which are more insulin resistant and more insulin deficient. You look at the comparisons between the classical type 5 diabetes versus the SIDD. The SIDD in this particular Indian publication, which is well cited, shows that they have a median BMI of around 24.9. So it's different from what we are seeing in type 5 diabetes. Another fairly large collaborative study from India once again shows, even though there's a range, they have BMIs around 24 to 25, unlike type 5 diabetes, which has a very low BMI. So let me summarize by saying type 5 diabetes is a very distinct metabolic entity associated with insulin deficiency, preserved insulin sensitivity, low total body fat, and a relatively reduced hepatic glucose output. Antenatal and postnatal undernutrition of variable degrees and in combination is responsible for the pathogenesis. Understanding the differential diagnosis of other causes of diabetes in the young and lean is critical, and using the appropriate tools to diagnose and manage these disorders is important. So we need to get better diagnostic algorithms, but keep these differential diagnoses in mind when you see a young person. I'd like to thank my funding agencies for having helped us with the research over the years, and multiple people from my department, and of course within India and international collaborators who have helped over the years. Thank you for your patient listening. I'd be very happy to answer any questions. Thank you.
Thank you so much, sir, for the presentation. We have a few questions here in the chat box.
Okay, thank you for that. And I have a few questions. So there's a very good question over here. How common is it in our population? I think is the first question. So we have an international estimate of around 25 to 30 million across the world, but I think it's a lot more than that. If you note, we have kept this cutoff of 19. But it doesn't mean that there are people who don't have a slightly higher BMI, say 20 or 21, who may have this disorder. We still do need to do a lot more work on this. In rural areas, in lower GDP parts of the country, and particularly in low socioeconomic groups, this is probably more common. So I would estimate that it's probably double the numbers of which I've just cited, number one. Number two, undernutrition of a fetus can occur even in a person who has placental insufficiency. So you think about a person who, say, has uncontrolled hypertension in pregnancy or first trimester diabetes. You could still have placental insufficiency, or you could have some other chronic disease which could cause low birth weight. So this did not happen in a low socioeconomic status individual. It can even happen with chronic illnesses per se. So we need to think about those conditions in addition, which can precipitate this disorder. Very good question over here. Difference between MODY and type 5 on history on genetic transmission. I think this is important. If you have a very strong family history of diabetes, the likelihood of this being uh, type 5 diabetes is much lower. I'm not saying it is impossible, anything is possible, but it is certainly much lower. This is usually a sporadic cause for diabetes. What age do you get MODY? Well, that's a very good question. So, MODY can occur, you can even have neonatal diabetes, which can be seen, like the ABCC8 and the KCNJ mutations. The classical MODYs, which we think about, is less than 25 years of age. But we know that monogenic beta cell dysfunction can be undiagnosed or underdiagnosed, and people may come only when they develop osmotic symptoms after the age of 30. So we do see patients who can present later as late as up to the age of 40 years with monogenic beta cell dysfunction. So drawing a good pedigree chart actually helps you out as far as the differential diagnosis as well. We have heard of type 1 and type 2 diabetes, and now it is type 5 diabetes. Okay, very good question. So, what it's a game of numbers that we see over here. Type 3 are the secondary forms of diabetes. Type 3 is what we talked about, pancreatic diabetes. The German classification of diabetes has diabetes in pregnancy as type 4. And incidentally, the current president of the International Diabetes Federation, Dr. Peter Schwartz, is a German. And that's why he gave this label as type 5 diabetes. At what age do you get MODY? I think I've answered that question. Um, can type 5 diabetes be diagnosed prenatally? I wish, I don't think I can, predict it over here. For that matter, there could be a number of other metabolic conditions which might, we may want to predict prenatally. Whether we'd like to actually put our mothers in an anxiety state by wanting them to know that in advance, the answer is no at this particular point of time. Are complications in type 5 diabetes, are they early? So that's a good question. Um, so there are two issues over here. The database that we have shown that the microvascular complications are not more than type 2 diabetes or type 1 diabetes. There are larger databases which suggest that the complication rates might be higher, but these are not being done in groups of patients which have had proper deep phenotyping. So, like, C peptide measurements, GAD antibodies, ultrasounds, large epidemiological studies wherein these have not been done. So, actually, the subtyping of diabetes in these large epidemiological studies have not been done. Uh, we don't know the proper answer to the question. The other fact is that those in low socioeconomic groups may also neglect their diabetes and therefore may have poorer control and therefore have greater microvascular complications. So the real answer, we don't know. They are less likely to have lipid anomalies Therefore, I would anticipate that macrovascular disease may not be as much a problem. But yes, we need to do more epidemiological studies to understand this. At the 10th week, if a pregnant mother is more than 110 milligram glucose, I think the question is incomplete over here. So, yeah, so from a management perspective, I have highlighted the fact that it appears that a good number, and approximately half of them, can be managed with oral antidiabetic agents, which is therefore worth trying, especially when you have these C peptides which are not rock bottom. They could respond to oral antidiabetic agents for a reasonable amount of time. I have recommended a high protein diet, but further research has to be done to validate this. Uh, and also the kind of amino acids which are required to stimulate the beta cell. I think a lot more work has to be done, but high protein diet and resistant exercises is what I've mentioned. How would you evaluate and manage 27-year-old lean male with a strong family history of type 2 diabetes who presents with recently detected fasting glucose of more than 200, improved to 150 with self-imposed diet? So I would like to ask you the first thing, what are the BMI levels, what are the stress levels in this particular individual? If the BMI levels are more than 30, the likelihood of this being type 2 is there. Because there's a strong family history, it could still be an overlap with the monogenic beta cell dysfunction. So the C peptides may give me definitely would give me a clue. If the C peptides are elevated, say 5 or 6, I know this is insulin resistance. If the C peptides were borderline, say 1.2 or 1.4 or something of that sort, the fasting state, then I would certainly consider a possibility of a monogenic beta cell dysfunction. I would, of course, also do an ultrasound to look at the liver to see if there's fatty liver. Presence of fatty liver, it's more in favor of a type 2 diabetes in this individual. I think that has covered, yeah, that's a good question which you actually asked. So you follow the algorithm which I've mentioned early on in the talk and look at these aspects. Incidence of underweight kids getting type 5 diabetes in percentage, yet to be elucidated. I don't think we have an answer to that question over here. So, but it's something to be kept in mind when we go backwards into the history and find out if there was a history of chronic undernutrition in childhood, which was there. Um, so, in my talk, I mentioned about SUs, DPP4s, and metformin in type 5 diabetes. I just mentioned this because these are the commonly used medications currently are armamentarium, because they do not have peripheral insulin resistance. I wouldn't anticipate pioglitazone being a particularly effective medication in treating these individuals. So that's why I didn't actually include that, and it hasn't been tried as well in these people because their beta cell function is low. Because they're already grossly underweight, I perhaps would not like to consider GLP-1 analogs as a treatment of choice, and particularly from the socioeconomic status that they come from, they may not. It may not be the best group of medications to try, and I certainly wouldn't try them with such low BMIs as well. How to differentiate between type 2 and type 5? The first thing is type 2 wouldn't have a BMI which is less than 20. I think I wouldn't use the term lean type 2 for a BMI less than 20 or 19. I would like to look at type 5 as a possibility. If the C peptides are low, that's actually very helpful in letting you know what's happening. At least in early disease, C peptides would be generally on the higher side in type 2 diabetes. So, catch-up growth during childhood can prevent, uh, I think you meant type 5 diabetes. Probably, difficult to know. Depends on also what kind of diet they've been having. The higher the protein diet, it may be protective for the pancreas. The higher the carbohydrate diet, the more likelihood of getting type 2 diabetes, which is something else which might be also a question later on. Can we decide about insulin depending on C-peptide levels? We haven't done discriminatory studies yet now, depending on the C-peptide levels as to when you should be giving insulin. But yes, perhaps. But I think the best thing is, because they are not prone for ketoacidosis, try them out on oral anti-diabetic agents first. If they don't respond, then use insulin. That's the thing that I would do rather than depend on the C-peptides in these patients per se. Average insulin. Okay, now this is a very good question, because the initial studies done um, by Samal and Tripathi suggested that the insulin requirements would be up to 1 to 2 unit per kg body weight, which is on the higher side, moderate to high. But what we have shown is that the insulin requirements aren't high. And there are so many variables, particularly in the lower socioeconomic group, which affect insulin injections. And, the initial studies done about 40 years ago were done in circumstances where the cold chain would have been affected. There were no glucometers available. And perhaps even defaulting from treatment might have been a lot more common in those days. Lipohypertrophy, etc., would have also been issues while injecting insulin. So our suggestions are that they do not require much insulin, because they are not insulin resistant either. Their hepatic glycogen storage may be on the lower side because of their socioeconomic status. They do not have a fatty liver. So um, by and large, their insulin requirements are not high. Generally, not more than 15 to 20 units of insulin per day is what we have actually seen. Once again, need more data to establish this, but this is basically the trend. No, type 5 diabetes is not the same as mitochondrial inherited diabetes with deafness. Certainly not. The second one is certainly much more uncommon condition, MIDD. And that, of course, you will find mitochondrial genes being positive over here. The T423 mitochondrial gene would be positive in these individuals who have a mutation. Can this diet? Certainly, carbohydrate intake has to be reduced. Because they are lean, you need to give them some degree of carbohydrates. The interesting thing is they don't tend to put on that much weight, even if they are reasonably well fed. Eventually, they don't tend to become obese, by and large. Do SGLT2 inhibitors have any role in such patients? Good question. Um, so the issue over here is SGLT2 inhibitors can also cause weight reduction. So that's one of the reasons I'd be more than hesitant to actually give SGLT2 inhibitors to such individuals. No validation studies being done with SGLT2 inhibitors though. Dietary restrictions, carbohydrate intake but lower, higher protein intake by and large. The exact proportions we need to work out. I think that's about it as far as the questions are concerned.
Yes, sir. Yes. That's all the questions from the comment section for now.
Sure.
If there are any more questions, the audience can drop in the comment section later, and I can relay them to you.
Yeah, and you're also welcome to send me an email. My email ID nihal_thomas@yahoo.com. You're welcome to drop emails to me in addition, and we're happy to answer your questions. Thank you so much for the privilege.
Thank you so much for joining us today on this important topic, sir.
Thank you.
Thank you so much.
Bye-bye.